Hello, I'm Betsy Ross, and welcome to this edition of Healthline. Eyeglasses and contacts have been correcting vision problems for many years. Well, now vision can be improved by a laser procedure. Today, we'll talk with Dr. Jean Knoll about who is a good candidate for this surgery. Dr. Heidi Murley takes us on a tour of the St. Luke's Center for Breast Health. And we are pleased to announce that our first segment today is being sponsored by Halpin Knoll Laser Eye Center. That's all next and more on Healthline, presented by the Northern Kentucky Medical Society. Well, of course, not everyone has perfect eyesight, and now there is a laser surgical procedure that can correct many vision problems. Our first guest today, Dr. Jean Knoll, is a cataract and refractive surgeon with Halpin Knoll Laser Eye Center. Thank you for being with us, Doctor. And, you know, we hear a lot about laser surgery, LASIK. Tiger Woods has had it. LeBron James has had it. So some pretty important athletes have had it. But we hear the term and maybe don't know exactly what it is. Explain to us what laser surgery is.
Well, laser surgery is a way to reshape the cornea to correct common refractive errors such as nearsightedness, farsightedness, and astigmatism.
So what makes this different from anything else or any other treatment that we had in the past? Because usually you just put on a pair of glasses and go.
Well, you can still correct your refractive errors with glasses or with contact lenses. And many years ago, we started out with a refractive procedure called radiokeratotomy, and that did work, but we had limited people we could correct. With the laser, we're now able to correct greater degrees of nearsightedness, astigmatism, more astigmatism than we could with RK, as well as hyperopia or farsightedness, which we could never do with RK, and with greater accuracy and to larger degrees.
And you talked about those three conditions, farsightedness, nearsightedness, astigmatism. Let's look and explain exactly what those conditions are.
Okay. Well, normally light rays enter the eye and they're bent or refracted to the back of the eye by the cornea and the lens inside the eye. If the light rays are focused in front of the eye, it's a condition called nearsightedness. Those people can usually see up close, but they can't see far away. The opposite is true in farsightedness. Usually the cornea is flatter or the eye is shorter, and in that situation the light rays are actually focused behind the retina, and those people actually have more problems up close. Astigmatism is, the perfect eye would be a baseball. The astigmatism is more like a football. There's different curvatures based on the different meridians of the eye.
So you talked about how usually we've had glasses or contacts. Now we can do LASIK eye surgery. Tell us a little bit about the procedure.
Well, LASIK stands for laser-assisted in situ keratomileusis, which basically means that you're going to reshape the cornea with a laser beam. The LASIK procedure itself involves cutting part of the cornea out of the way, then reshaping the cornea, and then putting that piece of cornea back. Because you are cutting the cornea, that's what gives you the rapid visual recovery. That cornea is alive, and when you put it back, it may be dried up, and you may have a couple hours of blurred vision, but the vision does return very rapidly. This is the laser beam actually reshaping the cornea based on what the refractive error is. It is a cool laser beam, and it's called an excimer laser. When the procedure is complete, the cap is put back down, and usually after a couple hours, the vision returns to a very good level.
Now, who would be a good candidate, a typical candidate for this kind of surgery?
The people that we're able to correct are people who are either nearsighted, farsighted, or people with astigmatism associated with those conditions. They also have to be in very good health as far as their eyes are concerned and can't have any other diseases that might make their outcome less predictable.
And I noticed on one of those slides it says you cannot do this with presbyopia, and that's, you know, the short arm disease that we all get if we live long enough, that you have to have readers. This does not help that condition.
It does not. Presbyopia is a condition or a problem with the lens inside the eye, and you're not going to reshape the lens. The only way you can attack that problem is if you decide to leave one eye for distance and one eye for reading. It doesn't make both eyes capable of reading and both eyes capable of seeing at the distance.
So now, let's say I want to go in and I want to see if I'm a good candidate for this. What kind of tests, what kind of measurements will you do to make sure that I can be a candidate for this?
Well, we do a complete eye exam. We check your vision. We dilate you. We make sure you don't have cataracts or other diseases that would cause a poor outcome. We also do further testing. We try to actually look at the eye and decide if it has a lot of aberrations in it that would give you poor quality vision after a standard laser, or help us determine whether you need a custom laser. We also do topographies of the eye, which means we map the hills and valleys of the eye to see if there's any problems with the cornea itself that could result in a bad outcome for the patient.
So let's say I'm a good candidate and I go in there for the procedure. You mentioned that it takes a couple of hours for everything to heal and settle down. Outpatient surgery?
It is an outpatient surgery. You usually have to arrive 30 minutes to an hour before just to be prepared. Then you're taken back to the laser room, and the actual procedure takes around 7 minutes an eye. And then usually we will keep you there for another 15 minutes after the procedure, and then you're sent home, usually with shields on the eye or goggles on the eye.
Now, will you do both eyes at the same time, or do you do one, leave, and then come back?
That is always the patient's choice. Some people do choose to do one eye at a time because they are conservative, but in this country and in our practice, we usually do bilateral surgery.
So you can resume normal activities fairly quickly.
You can resume normal activities usually within 2 hours. There are some restrictions. We don't like you to swim usually for 2 weeks. We don't like you to knuckle rub your eye for around 2 weeks. But you can exercise and do other things like that the next day.
And can I drive right away, or do I have to wait?
We usually suggest you wait until the day after the procedure because we do give you some relaxation medicine during the procedure.
Now, more and more people are having this procedure. More and more younger people are having it because they don't necessarily want to fiddle with contacts and they don't want to go to school with glasses. Is there an age or an age limit that you suggest that people can start thinking about it, or are some people just too young?
The FDA recommends 21 because at 21 we feel that the refraction is usually stable. However, we will do a patient that is 18 if we have a history that they've had an unchanging prescription for at least 1 year. But if I'm doing an 18-year-old, I usually like them to be stable for at least 2 to 3 years.
So if I'm 18 and I have this done, does that mean I'm going to have to come back? Because our eyes are always changing as we age. Does that mean I'm going to have to come back in 5, 10 years, have something else done?
At 18, there's a very good chance you will become more nearsighted or change in your 20s. So you may have to come back in your 20s to get what's called an enhancement or a touch-up to get you to the vision you want to achieve. Even though it's less likely to occur in the older patient, some of them still change 9 and 10 years out, and some of them will come back to you at that point and request a touch-up.
And, of course, the advantages to this, so many people, they don't want to have to put on their glasses when they look at the alarm clock, just little things like that.
That's correct. And you don't realize how important that is if you've never worn glasses, but some people can't even see the soap in the shower when they take a shower. So it is a life-changing experience for a lot of people.
Doctor, it's a fascinating procedure, and I know it's becoming more and more popular, not just in this area, but around the country. Thank you so much for being with us today.
Thank you very much.
And we'll be right back after this break.
Practice does make perfect. Something she'll understand more and more over time. Like how experience matters when choosing a heart program. At St. Elizabeth Medical Center, we've performed over 10,000 open heart surgeries and saved countless lives. Numbers like that add up to something she can understand today, and that is that her dad's back in her life. St. Elizabeth Medical Center, how medicine should be.
And now for Medical Minutes. The American Optometric Association has recently issued a warning to parents that their children might be developing computer vision syndrome due to prolonged time on the computer. 1 out of 2 children spends more than 4 hours a day in front of a computer screen, so parents should watch to see if their child is showing signs of eye strain. Rubbing the eye redness, or complaints of blurred vision may indicate a problem. They suggest that children take at least a 20-second break for every 20 minutes on the computer. Check to be sure there is no glare on the computer screen. And remember, if your computer workstation is set up for an adult, you might need an adjustable chair so your child doesn't have to look up to the screen. Our next story may offer some potentially good news for those suffering from hot flashes. A preliminary 6-week study at the Mayo Clinic shows that women cut the number of their weekly hot flashes in half by eating 2 tablespoons of ground flaxseed twice daily. It was mixed into cereal, juice, fruit, or yogurt. And although these preliminary findings need to be studied further to confirm their results, women can test these findings themselves by incorporating the healthy flaxseed into their diet. Who knows, maybe this tiny seed will bring welcome relief to a big problem for menopausal women. That's the Medical Minutes for this edition of Healthline. We'll be back with more after this.
Jar lid stuck again? Uh-oh, there must be an easier way to open that jar. Introducing the One-Touch Jar Opener, the fast, easy way to open jars. Just place on the jar, touch the button, and your jar opens in seconds. The One-Touch Jar Opener is totally automatic. Amazing! Best of all, it works on any size jar, small, medium, or large. It's so easy, anyone can use it. Get the One-Touch Jar Opener for the breakthrough price of just $19.95 with a money-back guarantee. If the One-Touch isn't the easiest jar opener you've ever used, just return it for a full refund. Call right now and we'll give you the One-Touch Bottle Pourer. It makes heavy, awkward bottles easy to handle, helping eliminate messy spills. A $10 value, yours free. Just pay shipping and handling. Don't wait. Call now.
Have your credit card ready and call 1-800-585-0894 to order the One-Touch Jar Opener for just $19.95 plus shipping and handling. That number again is 1-800-585-0894. Call now.
We are at the St. Luke Center for Breast Health. Dr. Heidi Murley is the medical director here. Of course, this is October, Breast Cancer Awareness Month. It's a good time not only to remind women of self-examination, but this is a great opportunity for us to take a tour of the facility and see what kind of options you have here for treatment and for diagnosis. So let's take a tour. Right this way. The examination room will be the first place that you will see a lot of the women who come here to the breast center. Now, who is the typical, if there is such a word, typical patient? Is it someone who's already been diagnosed, someone who suspects, someone who has a history of breast cancer? Who will you see?
I see women here with a broad range of breast health concerns. We may have a woman who feels a lump who's not had any imaging studies that we need to assess. We may have a woman whose sister was diagnosed with breast cancer or whose mother died of breast cancer who simply wants to know that her breast examination is normal and know what screening she needs. And then we'll see patients that have already gone through the diagnostic workup, that have had a mammogram ordered by their primary physician, have had a biopsy, and they know they have breast cancer. They're here for advice as to what they might need next.
And here at the breast center, you have specific days where you have every expert that you need to treat these issues.
That's true. When we have our breast center days, we have a medical oncologist, a radiation oncologist, our pathologist upstairs, our radiologist upstairs. All of us work together to try to provide a multidisciplinary approach for our patients. If I have a question about whether a patient would need radiation or is having a problem with their chemotherapy, they're right next door.
And let's talk a little bit about that. As a surgeon, of course, you see firsthand exactly what the issue is. What is your role once the surgery is done dealing with the patient?
I think that the breast health specialist role is to follow a patient after they've been diagnosed and treated for breast cancer to make sure there are no signs of recurrence. While we're doing that, we may alternate a follow-up schedule between other doctors involved in the care, one of the oncologists, for example. They may see patients once a year. I may see patients once a year. We try to make sure that someone is seeing that patient every few months the first year, and then after that, every 6 months or annually.
Well, hopefully, patients have gone to their doctor, maybe get a clinical examination of their breast while they're at the doctor, of course, doing self-examinations every month. But another line of defense, if we want to call it that, is the mammogram. Let's talk a little bit about getting a mammogram. Who should get a mammogram and how often?
I think that every woman at the age of 40 should start getting an annual mammogram. Women younger than 40 maybe need mammograms. It depends on their family history. Anyone with a strong family history or a breast concern ought to see their doctor about whether or not they need a mammogram.
So let's say a 40-year-old has not had a mammogram before, no history of breast cancer. She goes in, and she gets what is called a baseline mammogram. Now, explain a little bit about what that is.
A baseline mammogram would simply be her first mammogram, and that would be used in the future to compare new films against. One of the things that we look for when we look at mammograms is, has there been any change over time? Is there a new area of density or calcification that might need a biopsy?
And, of course, I guess probably the question you get all the time is, does this hurt?
Some women consider it a little bit uncomfortable. Basically, the breast is placed here. This is adjusted based on the patient's height, and the breast is gently compressed by this plate here. Then x-rays are taken. This swivels in different directions so we can give views in different orientations, top to bottom, side to side, for example.
So let's say that a follow-up mammogram, there's something different this year in the mammogram than from last year's. Next step, what might that be? What might the doctor order then?
Probably the first thing we would do if there was a change on the mammogram and nothing else on clinical exam is get an ultrasound of that area. That's an effective way to tell whether a density is perhaps solid, perhaps cystic, or maybe there's nothing really there. If we see something abnormal on an ultrasound that looks suspicious, we can consider a biopsy.
And of course, past that goes treatment. We'll talk about treatments here in just a little bit. We'll take a look at some treatment in the radiation room.
Okay.
But Doctor, you talked about the different treatments that would be available if someone is diagnosed with breast cancer. We're here in the radiation area. Who would get radiation treatment?
Well, breast radiation is given by this machine as a very common treatment for breast cancer. It's usually used for women that have had breast conservation or have chosen not to have mastectomy. Fortunately, in 2007, we're detecting breast cancers earlier. More women can be treated with lumpectomy without a mastectomy, and those women do need radiation to decrease the risk of a cancer coming back in that breast.
Now, if someone goes through radiation treatments, how often, on average, will they come in for a treatment?
A treatment in a room like this would be about every day for a period of 5 to 6 weeks. Usually treatments are brief, taking maybe 10 minutes at a time, and then most patients can get back to the rest of their day.
We're hearing from this machine a little bit of a hum. Of course, it's not on, it's not fired up. Will it get any louder? Is it uncomfortable for the patient at all?
No, this is the background noise that the machine makes. There will be a slight increase in the noise level during the treatment, but it's not uncomfortable.
Another option for treatment, of course, chemotherapy. Let's go to the infusion room and see that area.
Okay.
Another way of treating breast cancer, or several types of cancer, is chemotherapy. And I think we hear the term chemotherapy a lot, but we may not know exactly what it is. What is chemotherapy and what does it do?
Well, chemotherapy is a word we use to describe a variety of intravenous agents that we use to kill cancer cells. They travel throughout the body, unlike radiation, which is targeted at a specific body part, for example, the breast for breast cancer. Chemotherapy would go through the bloodstream to every organ. It kills any cells that may have spread outside the breast. Those are cells we call metastatic cells.
And here in the infusion room, you have comfortable chairs set up here. You have the poles for the IV. People come in on an outpatient basis?
Yes, people will go home the same day after a chemotherapy treatment.
You mentioned that the treatment with radiation is very targeted. Chemotherapy is more widespread through the body. Is it used in tandem? Are they used together? Do some get chemo, some get radiation? I know it varies with patients, but exactly how does it work?
Well, almost everyone will need surgery. Some people need radiation, some people need chemo, and some people need both. Women who need both will usually get chemotherapy first. Not always, but usually. Chemotherapy has the advantage of going throughout the bloodstream to kill cancer cells that could be hiding anywhere, but it's used in women that have high risk for having metastatic cells elsewhere, women that might have tumor in lymph nodes, or women that have big tumors, maybe young women that have a poor prognostic indicator on their pathology report.
We're back here now in the waiting area of St. Luke, but this also doubles as a meeting area for breast cancer support groups. And we've seen a lot that goes on here, the treatment, the diagnosis, so much. But one thing I think that we've seen is that it's not just a one-step process. It's not just have surgery and go home, or have treatment and go home. This is really a series. It's a process that a patient goes through.
That's true. It is a process, and it's a process that takes a significant amount of time. It can be stressful for patients and for their family members. We try to take families into account, too. Family members are a great source of support for their loved ones that are undergoing treatment, but they need support, too. We have nurse navigators that can help support our patients and their family members from the very first time they have an abnormal mammogram all the way through treatment and even recovery.
And you talk about the families. Really, this is a disease that does not just affect the patient, but it affects everyone. And you really invite the families to be a part of this treatment.
Absolutely. That's ideal. I think the more we engage the patient support system, the better care we give.
Well, Doctor, October, we always talk about breast cancer and breast health. It's a one-year reminder, but we should think about this all year round. Thank you so much for the tour. Great work here. Thanks so much for taking your time.
Thank you.
And we'll be back with House Calls right after this.
Practice does make perfect. Something she'll understand more and more over time. Like how experience matters when choosing a heart program. At St. Elizabeth Medical Center, we've performed over 10,000 open heart surgeries and saved countless lives. Numbers like that add up to something she can understand today, and that is that her dad's back in her life. St. Elizabeth Medical Center, how medicine should be.
Would you like to double, triple, or even quadruple your income and eliminate your credit card debt?
I make $5,000 a month of residual income.
Income is at a six-figure income. We'll be making over $8,000 a month this month.
Our first month, we made over $3,000 right out of the gate.
Thousands of people are getting started by requesting a free DVD that shows them the way to financial freedom. Like Trina, a soccer mom who started her home-based business part-time and with the help of a mentor made $30,000 the first year and $130,000 the next. Or Brandy, who has now become financially secure and is living the American dream.
The free DVD really opened my eyes.
We made over $18,000 last month.
And there's no experience necessary. Our DVD shows how a mentor works with you to assure your success.
Go to 92getmoney.com and get started today. And respond now while this is still a free service. Go to 92getmoney.com. That's 92getmoney.com. 92getmoney.com.
Our House Calls segment gives you, the viewer, an opportunity to ask questions about your medical concerns. We have doctors from the Northern Kentucky Medical Society ready to answer your questions. Our first question comes from Betty in Erlanger. For the last 5 years, my husband has been having stiffness in his right hip. It really doesn't prevent him from walking, but it is difficult for him to bend, to get dressed in the morning, like when he puts on his socks. How can we find out if this is arthritis? We asked Dr. Samar Hassan to answer this question.
Betty, I'm sorry that your husband's having trouble putting his socks on and off. The stiffness that you're describing may, in fact, relate to arthritis. Arthritis is the loss of the normal cartilage that lines healthy joints, but only an X-ray can help sort that out. In advanced cases, you might find a bone-on-bone appearance where there's no cartilage whatsoever. And when that happens, there's increased friction, which can lead to grinding. It can also lead to stiffness and to pain. So we really want to know if your husband's having pain with these events or other activities. But I also got to tell you that stiffness can relate to causes other than arthritis. For example, stiff tendons or inflamed tendons. And if that's the case, those generally respond to stretching exercises and anti-inflammatories. The stiffness may also relate to conditions outside of the hip. For example, low back pain or sciatica. Only your doctor can examine the hip, order x-rays and additional tests, and arrive at the correct diagnosis.
Dr. Tom Bonnell answers this question from Kevin in Latonia. I'm 45 years old and I've been a lifelong smoker. I know it's bad for my health, but I don't think I can quit. What would be the best way for me to stop smoking?
Kevin, don't despair. You can quit. You just have to keep trying. Nicotine is very addicting and it affects people in different ways. And that's one of the reasons whenever you try to quit that you get those feelings of anxiety and stress after you've not had a cigarette for a while. There are a number of programs in the community that I think that you might find very successful. And I think if you see your physician, he can certainly help you with it. There are a number of over-the-counter medications, nicotine patches, gum, and a spray. Also, if you're seeing your physician, he can prescribe something called Zyban, which will help somewhat with the anxiety symptoms. And there's something new that's just recently come out called Chantrix, which the manufacturer is claiming a fairly high rate of success with. So don't give up. There is help, and see your physician.
Our final question comes from Mike in Crestview Hills. This last year I've taken up running. Lately I've noticed pain in my knees, and a friend of mine told me that this might be caused by the type of shoes I wear. Is this possible? And if so, can I be doing damage to my knees if I continue to run? What should I do? We went to Dr. John Larkin for this answer.
Well, in actuality, that is possible. And pain in your knees is very common with running. In fact, it's probably one of the most common complaints that we see as physicians with sports medicine. Most of this is related to your kneecap, or what's commonly known as the patella. And kneecap pain can be related to shoe wear, especially in runners who have what are commonly referred to as flat feet. In people that have flat feet, especially it's important for them to look at changing their shoes about every 500 to 600 miles of running, which seems like a lot, but it's really not, especially if you're running 5 miles 3 to 4 times a week. So the good news is that it's not something that is damaging to your knees. The pain usually occurs after running and is what we commonly call patellofemoral pain or chondromalacia. The treatment for it is actually the proper shoe wear, and a couple of places in town are very good at fitting runners for the proper shoes for this. Most of it can be treated conservatively with physical therapy, with about 92% of people having full resolution of their pain with running.
Thank you, Doctor. Thanks to Dr. Hassan, Dr. Bunnell, and Dr. Larkin for their professional medical advice. Well, we've come to the end of this month's show. We would like to thank our guests, Dr. Jean Knoll and Dr. Heidi Murley. We also want to thank our segment sponsor, Halpin Knoll Laser Eye Center, for their participation. And today we want to also acknowledge that we have reached a milestone here at Healthline. It is our first anniversary since going on the air last October. We want to give special thanks to all of our guests, our sponsors, the Northern Kentucky Medical Society, and of course, you, our viewers, for all of your support this past year. I'm Betsy Ross. We will see you next month for another edition of Healthline.
Everyone loves Insight's bundled cable, high-speed internet, and phone. And when our customers speak, we listen. Due to overwhelming response, Insight needs to expand its direct sales team. If you have a positive attitude and can work independently and are interested in a dynamic outside sales position with outstanding earning potential and excellent benefits, plus discounted services in your home, come grow with us. Apply in person at our Florence office or send your resume to Insight.